A very good afternoon, everyone. So we'll begin the session on Squint. Already we are running late and we are two speakers. So I am Dr. Gunjan and I'll be talking on monocular elevation deficit. And we have on our dais Dr. Minakshi, who is from Arvind Eye Hospital, an eminent strabismologist. Uh, so to begin with, I'll be talking on monocular elevation deficit. So it is the limitation of elevation of the affected eye with normal inductions in all other cases, and this limitation in elevation is present both in abduction as well as in adduction. It is frequently associated with ptosis, pseudotosis, Marcus gun jaw winking phenomena, and has a vertical deviation which is usually associated with it. So, according to Ziffer et al., depending on the underlying etiology, it has been classified into three types. Where type 1 is caused because of the inferior rectus restriction that can be a result of either trauma or it can be because of autoimmune diseases like sarcoidosis or can be a result of thyroid eye disease at times, and the type 2 MED results from superior rectus palsy, which can be because of congenital causes, post traumatic causes, and MED3 results from the supranuclear causes, again, that can be post traumatic or can be because of the neonatal hypoxia. So, I'll be discussing some of the cases of monocular elevation deficit, and based on this, we will be discussing how do we approach these cases. So, this is one of the patient. He's a 15-year-old male. He presented with severe congenital ptosis. Along with that, he had a hypotropia. There was Marcus gun jaw winking phenomena, and there was elevation deficit with hypotropia. So the initial plan was to do the forced duction test, and on forced duction test it was found to be positive for inferior rectus, and hence the plan for inferior rectus recession was made. An inferior rectus recession of 5 millimeters was done, and this improved not just the hypotropia but also the ptosis of the patient, as we can see in this image. Similar case was with a 20-year-old male. He had a history of RTA, and following that he developed limitation of movements in the up gaze. On NCCT we found that the inferior rectus was not entrapped and there was no evident orbital fracture. There was a hypotropia of 25 prism diopters in primary. So a forced duction test was done for inferior rectus and it was found to be tight. Again, an inferior rectus recession was 5 was done. There is a reason why I am limiting to 5 millimeters, and that is because if we do it beyond 5 millimeters, there is a risk of lower lid retraction. And this is another case of a 25-year-old female. She had cysticercosis on her CT scan, and FTT was tight for inferior rectus. Following that, inferior rectus recession of 4.5 millimeters was done. So this is the pre-op 9 gaze and the post-op 9 gaze, which clearly shows the improvement in the elevation in this patient. Now, these were the one variety of cases where the inferior rectus was tight. Now, the second variety of cases are those where the inferior rectus will be free. So, this is one such case where a 20-year-old female presented with complaints of elevation deficit with drooping of left upper lid. Again, she had a complex ptosis with Marcus gun, and she had a vertical deviation of 25 prism diopters. Along with that, she also had a horizontal deviation of 50 prism. Her forced duction test was free, and hence the plan was a modified NAPS procedure correcting both the horizontal. In order to correct the horizontal deviation, a horizontal muscle recession resection was planned along with its transposition. So this was the pre-op and the post-op of the patient, showing an improvement in the hypotropia as well as slight improvement in the hypotropia as well as the improvement in the elevation was seen. The bells definitely improved, and following that patient underwent a ptosis surgery also. So this was another similar case where the patient had a stage surgery, first for the correction of squint, and following that she had the surgery for her ptosis following the improvement of bells. Now, this is another case of type 2 monocular elevation deficit where the inferior rectus was found to be free, and hence the plan, because the patient had esotropia, the plan was medial rectus recession along with lateral rectus resection and superior transposition, and we can see the images that there is a gross improvement in the elevation deficit as well as in the horizontal deviation too. and another case of type 2 monocular elevation deficit where the similar plans were done. So, if you look in a algorithm, in a gist, so first of all, the indications of surgery in monocular elevation deficit, as we saw in all the previous cases, was there was a very large vertical deviation, there was amblyopia, there was anomalous head posture, patients wanted correction of ptosis, they wanted improvement in the bells, and so we opted for these surgeries. Second thing is, how do we approach? So, the first thing, whenever you are planning the surgery for MED, is to go for a force duction test. If the force duction test for FDT is free, then you can plan for a NAPS procedure. And if it is tight, then inferior rectus recession up to 5 millimeters can be done with slight nasalization to avoid any pattern in the post-op. However, if it is free, then go for a NAPS procedure, and if the horizontal deviation is also present, go for a modified NAPS. That means you resect the muscle and then you transpose it. The another viable option in these cases can be modified Nishidas or contralateral eye surgeries. Coming to the effectiveness of various surgical procedures, that will be in for inferior rectus recession, the average correction that has been reported in various studies ranges from 12 to 16. For NAPS, it ranges from 29 to 38. However, in patients with large vertical deviations, you need to sometimes put a suture in the horizontal muscle that is said to be an augmented NAPS, and it is said to be correcting 30 to 40 prism. The modified NAPS procedure corrects a horizontal deviation of up to 20 and vertical deviation of 25. And as I told modified Nishidas, there has been a small case report and few case studies which report that it can correct up to 30 prism diopters of vertical deviation. So, and my observation, one has to be careful with inferior rectus recession. Inferior rectus recession per se cannot correct more than 20. Each millimeter of inferior rectus recession corrects around 3 to 3.5 prism diopters of the vertical deviation. Excessive inferior rectus recession can lead to lid retraction. So, if you have any inferior rectus that is tight, along with that, if you are planning the surgery, you might add up superior rectus plication or superior rectus resection to that. You might need to even to perform NAPS or augmented NAPS after an interval of 3 months just to prevent the anterior segment ischemia. Modified Nishidas, as I had stated earlier also, is a safe option because it's a no tenotomy, no splitting technique where you simply have to pass a non-absorbable suture 12 mm from the limbus in the superior quadrant. But long-term results are still not known and we need larger studies for the same. For type 2 MED, in patients with coexistent horizontal deviation, you need to transpose uh, the resected muscle. Transposition of recessed muscle is said to weaken the effect of NAPS and can be avoided at times. For horizontal deviation less than 30 prism diopters, resection of single muscle and its transposition can be of help. For horizontal deviation more than 30 prism, patients are to be counseled for the other eye surgery. That means for the other eye you can plan for the inferior oblique total anterior positioning or a superior rectus recession in these cases. Thank you. Comments? Any questions?
Thank you, Dr. Kunjan. The most important thing is look for the Marcus Ganja winking phenomenon. Don't miss that. And look for the Bell's phenomenon. We don't want, when you're doing a ptosis correction, to go for overcorrection and then exposure keratitis and then re-releasing the whole procedure. So these are the two important things. We have done Nishida in one of the cases. 2 cases we have done.
Yes, 3 case report.
Long-term
Yes,
results.
long-term and a larger.
Yeah.
I think the institute was the first to report 3 cases of JEPOs.
Yeah.
Yes.
So we have done that. It is the only thing is there is no involvement of we are not cutting off the blood supply to any of the things. So no question of any anti-resecant ischemia, and it is reversible also. One time, it was a very 25 prisms, and the surgeon, one of my colleagues, she wanted to do, and okay, the next day we saw that it was overcorrecting. We simply released, and we got away with it. So that is one way it is good compared to transposition procedures or naps.
Moreover, we can plan in the same sitting.
Yes.
We don't have to wait for 3 months
Yes.
for prevention of this. So, next, I would like to invite ma'am. She's the Chief Medical Officer and Head of Pediatric Ophthalmology Services at Arvind Eye Hospital, Tamil Nadu. Ma'am will be talking on Brown syndrome, case-based approach and on the management.
Good afternoon. It's a small crowd, so thank the AOS for this wonderful opportunity. So Brown syndrome is a very rare entity which has been there from time immemorial. This is a picture of Henry VII, where you can see in the second picture the mild right hypotropia and the face turn. So he had congenital right Browns. So these are the main features of a Brown syndrome: the decreased elevation of the affected eye in adduction, on adductions and versions, the progression of the decreased elevation in adduction to full elevation. This whole thing, no, it's a straight line. So this we have to, this is one important point. In straight gaze, there is either an exotropia, which produces a V pattern, or the eyes usually remain straight. And in adduction, there may be a downshoot of the affected eye, and sometimes hypotropia in primary position. Compensatory position, head posture may or may not be there, which can be a chin up or a face turn to the contralateral side. The last important point is a positive force duction test. So the etiopathogenesis, there is still no clear-cut this thing. Previously they said that it was the sheath that is this thing, but now the whole thing seems to be into the tendon and the trochlear complex, which is not functioning well. So coming to the classification, Brown, who did a lot of work on that, it can be true or pseudo Browns. True is the typical one, the congenital one, where you have a constant limitation of elevation and a positive FDT due to a tight superior oblique. Or a pseudo Browns, which is acquired, which can be traumatic, iatrogenic, or inflammatory. So these are not due to superior oblique tendon pathology. It is due to other causes. And one second. So the staging, it can be mild, moderate, or severe. The mild, you just do not have a downshoot or no hypotropia in primary gaze, just elevation restriction in adduction. In the moderate cases, you have a downshoot in adduction and no hypotropia, whereas in severe cases, you have hypotropia with downshoot. So these two goes into Brown syndrome plus. So coming to the first case scenario, you have a 4-year-old male child. As you can see here, right eye squinting noticed by parents when child looks up at them. An uncorrected visual acuity of 6.6 both eye. No squinting in primary gaze. No abnormal head posture. And there is limitation of elevation in adduction. And you can see the progressive increase in elevation in both eyes from adduction to abduction. You can see that there is no elevation, is restricted in both the eyes. And so what do we do in this case, particular case? So wait and watch, because there is no abnormal head posture, no squinting, eye is straight. Don't jump into any surgical interventions. And it has been reported many times that spontaneous recovery can occur. As you can see in this picture, from 3 to 6 years, it increased. Even in 8 years, it was no better. But at the age of 18 and a half, eye is straight. So you just have to wait and watch, and do not touch such cases unless otherwise there is any need for it. So this is another case report by Lambert et al., where from even at 5 years of age, no change, but at 18 or 20, 22, it has improved to straight gaze and elevation has improved. So should we intervene in all cases of congenital Browns? The answer is no. So when do we intervene? We intervene only when there is a severe compensatory head posture, or there is a large vertical strabismus in primary position, or any troublesome diplopia. So this is the situation when there is a large head posture or a diplopia, then you intervene. So this is the second case, a 31-year-old male who had come with a history of squint in right eye since childhood. And there is limitation of elevation and adduction, right eye -4, as you can see here, there is this thing, and there is a mild downshoot also on adduction as shown here. So this thing shows 16 prism L by R with a mild esophoria also. So what next? In this case, we go ahead with the squint surgery. So coming to the surgical management in a congenital Browns, we have various options. You can weaken the superior oblique by tinectomy, tenotomy, or Z-tenotomy or recession. Or we can lengthen the superior oblique, thereby decreasing its function by all these expanders, nap chicken suture or tendon suture lengthening, or CNCR split tendon lengthening. So how do we do all this? The simplest is tinectomy or tenotomy. So in tenotomy, you go on the nasal side and then simply cut the tendon. So what is the disadvantage of a tenotomy is you are inducing a superior oblique palsy. So in the tinectomy, you cut a bit of the muscle, but the main, some surgeons after tenotomy, they also do a inferior oblique recession because you are inducing a superior oblique palsy. So usually we do not do at Arvid, we do not do a tenotomy. The another option is Z tenotomy, where you weaken the muscle by two cuts in the distance apart by 5 to 6 millimeters, partial cuts, and you get a Z-like tendon, which will lengthen the tendon or weaken the superior oblique, or the regular recession as you do for any other resect procedure. So posterior tinectomy doesn't work for Browns because both the anterior and the posterior fibers are tight, so we don't do PTSO. So these are some of the articles which have been published where they have a lot of people have done superior oblique tenotomy, and most of them were nasal, and a few of them have done temporal also. The temporal, it is the muscle is spread out, so prefer a nasal tenotomy. So what did we do in this case? We went, this is Dr. Sandra's this thing. First always do a FDT. Don't push the eye too much into the globe. Check for the tautness of the superior oblique. And then you go ahead with the nasal approach. This is what you do a good conjunctival phonics based incision and expose the superior rectus, and around 7 to 8 millimeters from the insertion you will have the superior oblique tendon as a nice taut this thing. But sometimes we may miss this and cut it also. So as you can see, even in the superior rectus, we have not crossed the gone to the temporal side, as you can see here. And here you nicely dissect the sheets and this thing. And now you go ahead with a non-absorbable suture. Take a measure around how many millimeters ever you want. You can do it usually around 8 millimeters. So 4 millimeters gap you give, so that because when you put then on a loop it becomes 8. So this is a non-absorbable ethibond suture, double armed. So both sides you can do it and loop it. The main thing is when you are doing this is you can get entangled. So this has happened for me in the initial stages. And for better visualization, use the Desmar's retractor. Ask your assistant to hold it. As you can see here, it is beautifully done. And then you just have to cut the muscle in between and the procedure is over. So this is the simple chicken suture lengthening procedure. The same thing, similar principle is the silicone expander. Instead of taking a loop like this, you just have to use a silicone band 240 and do this thing. So this gives good results. I have done few cases of this, and so far touchwood I have not had any issues with any tissue reaction or anything because of the ethibond, but that can happen. But with silicone expander, yes, it can extrude, so that is one disadvantage with that. So this is the post-op day 1. You can see that there is no downshoot here, and you can see that mild increase in the elevation. See, the whole point of doing this surgery is not to improve the elevation, but to improve the head posture and the downshoot. We cannot always make it fully functional. Same with advance also. So these are some of the other studies. And the other thing, third case we had was intermittent Brown syndrome. 10-year-old female, occasional double vision on looking up with a clicking sound, which gets relieved on digital pressure, and no squinting or no abnormal head posture, just observe. So this is a case report which says that don't do anything, just apply this thing, pressure on the nasal side on the trochlea, and the elevation happens. So why the click? They say that it is because of fluid accumulation in the trochlear space there, which gives rise to this click sound. But not many human studies to go and study how the tendon trochlear complex looks like, is because we don't do that. So natural history is, does it progress or resolve? Most of the cases it resolves spontaneously. That is a natural history of this thing. So this study has told that Barry et al. In 2009, spontaneous improvement in around 75% of the patients. So the other case which we saw was on 27-year-old female, sudden onset of diplopia, one day duration, more on right gaze. The thing is systemic examination, because we got the history and the patient also revealed, otherwise we never see the foot or the hand, this thing of the patient. We always see the eye or the face, and we miss this important finding, both rheumatoid arthritis or scleroderma. This turned out to be a scleroderma, and with Raynaud's phenomenon, young girl, and still remember the case with, and previously treated with oral prednisolone. So she had flexion contractures, all that. And so with this particular case, there was a mild exophoria, FDT was positive, and ANA profile was also positive. And we started her on oral prednisolone 20 milligram daily for 1 week, tapered over a period of 2 weeks time. And the resolution happened. And as you can see here in this picture, the whole elevation is now better. So what are the causes of acquired simulated Browns? It can be any of the inflammatory disorders, all your rheumatoid arthritis, SLE, all those can cause, or trauma can cause this pseudo Browns, and tumors, or even post surgeries, all our GDD implantation, ethmoidal sinus, or the most important thing is superior oblique tuck, which we do for a congenital superior oblique palsy. So after a tuck, always do a force duction test to make sure that you don't induce a Brown. So that is one important thing. Or surgical repair of a blowout fracture, you can have this. So in an acquired Bounce, you wait for we may sometimes undergo a spontaneous resolution, or we may need to have systemic steroid or local steroid injections, or immunosuppressants in refractive cases. So this is there are some case reports following COVID-19 and COVID infection acquired Browns. Not only Browns, we had all types of palsies also, which a lot of publications were there. So usually direct injections of methylprednisolone into the trochlear region can relieve these problems. So this is another case report following medial orbital valve fracture. And the another important thing is canine tooth syndrome, where you can have it following closed head trauma. It has been associated with when associated superior oblique palsy. So main thing is check the superior oblique before doing any surgical intervention. So the main differential diagnosis is inferior oblique palsy. Isolated is very rare. So a positive PAC 3-step test will help in this thing, and positive FDT, which will help in recognizing that it is an inferior oblique, and recession of the contralateral superior rectus is the answer. So, or you can have underaction of the inferior obliques in A and V patterns. That also in A pattern, esotropia, there can be a bilateral under elevation and adduction because of the underaction of the inferior obliques and corresponding overaction of the superior obliques. So this is a straightforward diagnosis. So here also we have to tackle the superior oblique. There PTSO will work. So this is one another case where anti-elevation effect following inferior oblique surgery, where we have done an anti-donasal transposition of the inferior oblique, and you can see that following that, you can see that there is an elevation deficit. So whenever someone sends a picture, recently I had a request from one of our former fellows from South Africa, asking whether she can go and operate on the other eye superior rectus to relieve the hypertrophy. I said, you first get the history and then explore and get it whether there was a oblique surgery done, because they had done the medial rectus. She was not sure if obliques were done. So anti-elevation effect can come when you are disturbing the fat also, this can happen. So the take-home message is it's a final common pathway for an inelastic tendon or a short tendon, small trochlea or disinnervation. So given the multiple causes, the same approach does not always work, nor the outcomes the same. So they vary across the board. I thank Sandra Ganesh for giving me this video and Pravina Sham for this presentation, helping in the presentation. Thank you. Thank you.
Aspects of Brown syndrome. So do we have any questions? Okay, so only one thing that is very true, that if you cannot rejoin, you should not cut it.
Yes.
So we should not do tenectomy or any as such. Sometimes people also do inferior oblique tendon cutting directly for the inferior oblique overaction. So that has to be avoided. Tenectomy is no more done. It is best to do the, as ma'am had shown, the suture lengthening procedure, which is the best one to go for in these cases. I think. Picture with the audience. Yes, we can have a picture with